All right, we move on to liver disease in pregnancy. And there are just a few entities that we want to talk about, which are unique to pregnancy. One of those is intrahepatic cholestasis. This is stimulated by estrogen in genetically predisposed women in the second half of the pregnancy, and these tend to be women of Northern European origin. There is a high recurrence rate with subsequent pregnancies. The risk is increased with twins or triplets, and the basic pathophysiology is bile acids are incompletely cleared by the liver and accumulate in the plasma. Overall prevalence, about 0.5% in North America and in Europe. The most significant symptom is itching, intractable pruritus, worse at night, but you don't see anything in terms of a rash on the skin. Laboratory tests. There may be a mild increase in bilirubin, but clearly the most diagnostic test is serum bile acids, and these can be increased many-fold. In terms of the mother, there's no significant impact other than the itching symptoms. But preterm births and stillbirths, intrauterine deaths are increased, and so antenatal fetal testing, NSTs, AFIs should be begun at 34 weeks. And I would deliver this patient by term. I wouldn't let her go post-term. After she has delivered, disappears. Symptoms are gone. The treatment, oral antihistamines if it is mild, cholestyramine, which prevents the intrahepatic circulation of cholesterol, but the treatment of choice currently is ursodeoxycholic acid, and that is the preferred treatment currently. The second significant liver disease in pregnancy is acute fatty liver. Acute fatty liver is uncommon, but it is life-threatening. Maternal mortality can be 50 to 70%. Prevalence only 1 in 15,000, and the etiology is a disordered metabolism of fatty acids by mitochondria in the fetus. This is really stimulated by the fetus. It is caused by deficiency in Ch10, which is long-chain 3-hydroacyl coenzyme A dehydrogenase. How's that for a mouthful? So this is an inherited disease and is a result of problems in metabolism of fatty acids by the fetus. The symptoms can be rather nonspecific initially: nausea, vomiting, anorexia, epigastric pain, jaundice and fever, and it can mimic preeclampsia, hypertension, proteinuria, edema, epigastric pain. That sounds like severe preeclampsia. This can progress to renal failure, pancreatitis, hepatic encephalopathy, and even coma. In terms of laboratory tests, what is unique is if you have a patient who looks like severe preeclampsia, but has hypoglycemia and hyperammonemia, increased ammonia and decreased in glucose, that's consistent with acute fatty liver. Why is the glucose level low? Because you have liver failure and you have decreased glycogen stores. Why does the serum ammonia go up? Because you don't have the clearance which the liver normally performs. Management, ICU care. This patient needs close monitoring. Hydration, careful attention, and prompt delivery. Will she survive? That's a major problem. And more than anything, it is supportive care. Supportive care and a lot of prayer. And that's the end of unique liver disease in pregnancy.